Okay, hello everyone, and welcome to Understanding Suicide Data in Utah, information you need to save lives. This is one of a series of webinars we hope to do throughout the year on the state suicide prevention plan. And we're grateful that you've chosen to join us today, or if you're watching the recording, we're grateful that you came back to watch. There is a poll that should be up on your screen just so that we have a better idea of who you are representing. My name is Heather Barnum. I'm with the Department of Human Services, and I will be helping to moderate questions today. Just a few housekeeping items before we jump over to our presenters, Michael Staley and Allison Foust. To accommodate as many people as we can on this call today, we've chosen the Zoom option that will not, unfortunately, allow us to see your faces nor hear your voices today. But we encourage you to put your questions in the Q&A button at the center of the bottom of your screen. We'll also be using the poll feature like the one you see up right now, and that will be also in the middle of your screen. You'll see those pop up throughout the presentation. You can also turn on your captions. So go ahead, and if you need captions, that is at the bottom of your screen as well. And with that, we'll let you know that this is being recorded for the benefit of those who could not participate live today. And I will turn the time over to Michael Staley and Allison Foust for our presentation. And Michael, if you want to close the affiliation poll when you get started and also introduce yourself, we appreciate your time. Thank you.
Great, thank you. I can introduce myself first. So as Heather said, my name is Allison Foust. I work at the Division of Substance Abuse and Mental Health in the Department of Human Services as our Suicide Prevention Administrator. I have the pleasure of presenting here with Dr. Michael Staley. If you want to introduce yourself, Michael, and who you're with.
My name is Michael Staley, and I'm the Suicide Prevention Research Coordinator and Epidemiology Manager at the Office of the Medical Examiner.
Great, thank you. And I'm going to apologize in advance. Whatever sickness has been going around has officially caught me, and so I'm hoping my voice will hold out, and I apologize in advance for anything the cold medication makes me say, but we're excited to spend this hour with you, and Michael's going to cover some really great content that we haven't been able to provide on this sort of a level before about the data that's available to you that will hopefully help you to inform your prevention efforts at a state level and a local level. So Michael, if you want to go ahead and go to my first slide.
You bet. And Heather, I cannot change the poll. It just says hosts and panelists cannot vote, and I have no option.
I noticed that too, so sorry about that.
No worries, we're good.
We'll get that. Oh, here we go.
Great.
Okay.
So it looks like most are state employees. That's awesome, 69%, but we're also so grateful to have our partners with us today as well, representing our local health and mental health, college and university, and our private partners and community members.
Thank you all for prioritizing this hour and being here with us this week. So what we're hoping you'll be able to walk away with today is a little bit of a basic understanding of what exactly suicide trends are looking like here in Utah, how you can obtain suicide data yourself and other public wellness measures through behavioral health indicator systems, how to interpret small numbers or what would be defined as like a big tragedy on a state or community level, how we actually use this data in prevention planning, and what is kind of happening in terms of suicide surveillance and what resources exist here in Utah. Next slide, please. So for those of you that are not familiar, I did want to provide a little bit of background information here. So every 5 years here in the state of Utah, we do publish a new state plan for suicide prevention. So this is our third iteration. We just launched this in October 2021. So hopefully a lot of you were able to join us for that first webinar and have come back to learn more. But in this state plan, we essentially defined some core strategies that we believe are important to be implemented in our state to be able to reduce suicides over the next 7 years. Some of these strategies include increasing access and availability to healthcare and behavioral healthcare, increasing social norms around help seeking and recovery, reducing access to lethal means such as firearms or prescription medications, increasing connection in individual, family, and societal institutions by creating safe and supportive environments, increasing coping and problem-solving skills, increasing support to those who have lost someone to suicide, and sort of broader economic supports that we believe are also important. Now, additionally, there are some other priorities that maybe not defined as protective factors for suicide, but certainly help us inform prevention. And so we've also prioritized engaging and supporting high-risk and underserved groups. And then what we're going to be talking about today is the importance of increasing comprehensive data collection for suicide, and how we use that data to guide prevention efforts. So if you haven't checked out our new state plan for suicide prevention here in Utah, if you visit liveonutah.org/about, you'll have access to the state plan and all the supporting documents that were created to guide efforts over the next 5 years. So I encourage you to check that out. Next slide, please. Now, we are really fortunate here in the state of Utah to have a lot of legislation that's really supportive of prevention. So here in our state, it's written as a policy that we have an operating state coalition, which in this case is called the Utah Suicide Prevention Coalition. You can kind of see our org chart down below. This coalition is really like our driving force to implement our state plan in collaboration with many of our state partners and private partners across the state. It's also written into statute that every 5 years we update that suicide prevention plan so that it reflects relevant research and continues to help us kind of move forward and reduce suicides in our state. So those two things are actually written into policy here. Now, what a lot of people don't know is there's also a policy that Utah has a suicide prevention state coordinator, as well as a suicide research coordinator position. Those positions are filled by Dr. Michael Staley as the suicide research coordinator and myself, who is the state prevention coordinator. Not only do these positions exist, but they're also required to have really intentional ongoing collaboration so that this data is really informing prevention practices. And so that's kind of like a really exciting step. Next slide, please. So what is the importance of collecting data? You know, this might seem like a really basic question, but I think we're at the point now in our state where we know that suicide is an issue, right? We're kind of past the point of using suicide data to raise awareness. What we need to be doing is using suicide data to inform action. And so our hope in today's presentation and the data that you will sort of have at your fingertips, hopefully leaving today, you know, with Michael's training and the information provided for you in the state plan, is that this data really is to provide guidance to our state coalition, our community partners, and local communities to be able to help them develop action plans to prevent suicide. We also are hopeful that this data helps us outline priorities for state agencies and legislators to make policy decisions to improve mental health. And just kind of keep tabs on what is happening on a trend level in Utah over time, and just kind of keep tabs on, you know, where we need to be adjusting our prevention efforts. So really excited to turn the time over to Dr. Michael Staley. We have a lot to get through, so, you know, bear with us, but I think it'll be really useful information, and I'm going to turn the time over to you.
Thanks, Allison. It's good to be with all of you today. And just seeing the poll that we started with today, I noticed a lot of you are DOH or DHS employees. And if you're familiar with how to use IBIS and CDC Wonder, just a heads up, we're going to be going to the suicide related indicators on that today. But if you know how to use those and you're very comfortable with those, this might be a little bit repetitive for you. I'm not saying that there's no gems in here, but just giving you a fair warning. I also want to talk about when academics and epidemiologists talk about suicide, because we often will say things are getting better, meaning the number of suicides went down or the rates went down. And what gets lost in that is that if suicides went from 640 a year to 620 a year, we view that as a good thing because they went down, but that still represents 620 people and 620 families who are dealing with the tragedy of tragedies. And that's not lost on me. That's not lost when I talk to families. That's not lost on most of you. So talking about suicide numbers is a bit of a sensitive issue. And I just want you to know that when you talk about suicide to your constituents and those who you might be talking to in trainings or what have you, but also we know that when we're talking about this important data as well. It's also really important to be specific about what it is that we're talking about. And so I want to tell you, when we talk about suicide rates, what is it that we're actually talking about? Because we could be talking about the people who seriously think about suicide. We could be talking about the people who attempt suicide but live, and then we could be talking about people who die by suicide. When we talk about the suicide rate, I think the connotation there is suicide death. But let's not forget that people who struggle with suicidal thoughts, that is a very life-impacting thing to have to encounter. Or people who live with people who have serious suicidal thoughts or who have attempted suicide, that is also a very serious issue that we should not downplay. Today, we're talking mostly about suicide death, this bubble, which is because that's where I spend most of my time investigating and reporting and understanding. But IBIS and other indicators do give us some tools to understand these other bubbles, and hopefully we'll be able to cover those some other time in the future. Just to show you the proportion of how those bubbles fit together. This largest circle that encompasses these two inner circles, that represents the number of people who seriously think about suicide. The middle bubble, the light blue bubble in the middle, these people actually thought about suicide enough to make a plan. This is getting very serious. And then people, 1.4 million adults attempted suicide. And then I did my best to put a circle outside of this because it's not clear how this fits in. About 45,861 people died by suicide in 2019, according to NIMH and SAMHSA. So when we're talking about suicide death, we're talking about the smallest circle, thank goodness. But suicides, the impact of suicide is huge. And in Utah, we know about 91% of all Utahns have either struggled with suicidal thoughts themselves, attempted suicide and lived, know somebody who struggles with suicide, or have lost somebody to suicide. It's a far-reaching issue. So you probably are familiar with this graph if you've been to any kind of gatekeeper training or anything like that. That shows the rate of suicide in Utah, crude rate per 100,000, compared to that of the United States. The rate of suicide in Utah has long been higher than in the United States, but it really started to grow at a higher rate in 2008. But in more recent years, really since 2015 or so, that has really leveled off a great deal. And we're going to spend quite a bit of time talking about these most recent years today as well. So what proportion, and this is not our poll today, but just in your own mind, answer this question for yourself. What proportion or percentage of all suicide deaths each year in Utah are 10 to 17-year-olds, otherwise known as teen suicide? I often hear 40, 50, 60%, and I don't blame the people who tell me that information, because if you Google suicide in Utah, the largest number of responses you're going to get is teen suicide, teen suicide, teen suicide. What I'm not saying is that teen suicide is not an issue, because it is definitely an issue in our state. But what I'm also saying is out of all the age categories that we look at, teens represent the smallest proportion of all age categories over time. We do need a strategy that prevents teen suicide, but we also need to make sure that our strategy works for elderly people, because they die by suicide too. And the bulk of people who die by suicide are middle-aged. Most of them are men. And so we need to take a life course perspective in any kind of suicide strategy that we create. And the data definitely tells us that that's exactly what we should do. This is just looking at 0 to 17-year-olds from 1999 to 2020. And as you can see, the rates really started to increase around 2007. And there was this great CDC EPI that came out in 2017 that looked at teen suicide in our state between 2011 and 2000. 2015, then documented 140% increase during that time. Now, the good news since then is that it is largely leveled out. Teen suicide is not currently still increasing. But as we're going to cover in this presentation several times, you don't need a suicide rate or a suicide count to be increasing for suicide to be a problem. Teen suicide rates in our state are very high. They are a big problem. They're some of the highest in the country. And our suicide rates overall in our state are also very high, and they are already a problem. We don't need these rates to be increasing to demonstrate a point that we need more resources. There is ample evidence now that we need plans, we need resources, and we need to take action. This is the proportion of how people, or the cause of death, how people died by suicide. 50% of Utahns used a firearm. Clearly, we need a strategy that includes means reduction, locking up firearms, making sure that teens don't get their hands on them, and making sure that adults know where to go or are comfortable having other people hold their firearms when they are going through some difficult times. A quarter of people die by asphyxiation. That's typically hanging deaths. Another smaller proportion dies by drug overdose. That's what accounts for most poisoning deaths. And then this other category has a broad range of methods of suicide in it. And there's more about that in our state plan. In fact, this data is from the state plan. Now, if you couldn't tell, I'm moving at breakneck speed today. This is definitely a seatbelts fastened, tray up version of this presentation. And I know that it's going to produce a number of questions that I'm not going to be able to answer in this presentation, but know that I'm absolutely willing to answer your questions and email you back. So please write those questions down, put them in the Q&A, and I'll get to them hopefully a little bit later. So if we could pull up our poll next, and the question here is, out of the data that I just gave you today, which I realize is 30,000 foot level, where did this data come from? Did it come from CDC Wonder, Utah Public Health Indicator-Based Information System, or from now on, I'm going to call that IBIS because I didn't even know what IBIS stood for until I put this on the slide, or top secret medical examiner data, A and B, or all of the above? I'll give you just a second to answer that. All right, let's close that poll. I'm sorry if you didn't have a chance to answer the question. We could display the result. Okay, awesome. So most people, nobody answered top secret medical examiner database. Thank goodness. So this information comes from CDC Wonder. That's the national data. And the rest of it came from IBIS. So the answer is A and B. Congrats to everybody who answered that question correctly. And for those of you who didn't, great news. Everything I just presented to you and so much more is available to you 24 hours a day, 7 days a week on what we call the Utah on IBIS. And that's where we're going to turn our attention next. I'm going to close the poll here. All right. Now, IBIS is designed to make data available publicly in a timely fashion. And I know there's probably some eye rolls out there when you're saying, wait a minute, the most current year on there for mortality data is 2020. Well, actually, that is the most currently available, publicly available year anywhere. And so IBIS is meant to give you this data in the most comprehensive way. We're giving you as much data as we possibly can without compromising people's privacy. And the ability to customize the data to your needs. Now, consequently, because it has that much data and it's customizable, it suffers a little bit in the user-friendly department. So we're going to build a query today, and I want you to be able to just feel comfortable getting into IBIS and starting to point and click and figure things out for yourself. But we're going to ask just a very basic question to start, which is how many people died by suicide in Utah in the past 5 years? Now, before we get to IBIS itself and building the query, where does IBIS data come from? Well, first of all, you have to understand the structure of how we investigate death in Utah. We have the Utah Office of the Medical Examiner, which is where I work. We're a centralized death investigation system. So if somebody dies in any unexpected way or violent way, so suicide, homicide, accident, all three of those, if we're suspecting any of those, all of those deaths, no matter where that person died, come to us for investigation at the Office of the Medical Examiner. There are no coroners in Utah. There are medical legal death investigators, and they are stationed throughout our state, but there are no coroners. So all of these decisions are made by one of our 9, soon to be 10 pathologists here at the OME. And that really brings together, we put our minds together on those difficult cases and standardizes what it is that we call a suicide and what gets called undetermined or accident or something else. So the medical examiner determines cause, and remember, cause is how that person died. So in this case, the method of suicide, and manner is suicide itself. When somebody says the cause of death is suicide, you've confused cause and manner. So the medical examiner then certifies those death certificates or signs them. And so remember that medical examiner data, and we'll always label it as such if we ever report it. We're really not talking much about medical examiner data here today, is occurrence level data. That is, where did that person die? Not where they were injured, not where they lived, but where was their death pronounced? That's important, as we'll discover in an example a little bit later. The second entity you need to know about is the Office of Vital Record and Statistics, which is also in the Department of Health, State Department of Health, or OVRS. This is the source of official vital statistics, including suicide stats that we report in IBIS here in Utah. So this reports the deaths based on place of residence, not place of death, and not place of injury, but where did that person actually reside? So the license typically on an ID or driver's license. All of our death certificates that the OME signs go into Vital Records. Vital Records owns the death certificates. OME simply acts as the entity that signs those for unnatural or unattended deaths. So the other entity you need to know about in this equation is the CDC, and specifically the National Vital Statistics System. This is how we learn about Utah residents who die in Wyoming, and likewise how Wyoming learns about Wyoming residents or Nevada residents, et cetera, for Nevada, that die in Utah. Now that's important because a lot of times people who are in critical condition are flown from Evanston, Wyoming or Elko, Nevada to Primary Children's or to one of our Trauma One centers at the U or at Intermountain for a higher level of care. But they are residents of Wyoming or Nevada respectively. And if they die, and people who are in critical conditions sometimes do, those death certificates, because that is a Utah death, that death was pronounced in Utah, that death certificate, for a lack of a better verb here, will be returned to Wyoming by NVSS after these death certificates are all reconciled. The other thing that you need to know as a side note is the funeral homes play a key role in getting and gathering data. And that might come as a surprise to many of you. Funeral homes don't ever fill out information about cause and manner of death or where the person died, but they do gather important information from families like race and ethnicity, level of education, marital status, veteran status, etc. And if family doesn't know or family wasn't asked, that information is not reported. All right, so now we're going to turn our attention to IBIS itself, and we're going to build a query from start to finish. You can go to this very same page. I took these screenshots just yesterday. Go to ibis.health.utah.gov, and this is what comes up. And you're going to start by clicking on the button that says Data Portal. After Data Portal comes up, you're going to select Injury Mortality. That might be a new place to click for people who are longtime IBIS users, but this is the easiest way to get to suicide information in a quick fashion. After you click Injury Mortality, this is the screen that comes up. Now, we're going to select Injury Crude Rates. Crude rates include the counts as well. So this is going to give us both the previous option and this next option. There are several other options here that you can choose from, important reasons for choosing them that we're not going to cover today. But one that I do want to point out, because many of you might be interested in race and ethnicity, that's actually not reported in the query that we are going to use today, but you can get that information by selecting this option down below in the advanced selection area, and then you can select race and ethnicity there. So you have to basically say, I'm not going to try to figure out who these people are. I'm not going to try to break this system by, violating privacy rules and contacting these people. So you're going to want to agree to that. Next, the first step here is to select the years that you want. The years that are available in IBIS go back to 1999. You can select multiple years or any item by holding down the control key, or if you're using an Apple, you can hold down the command key and select those multiple years. Control A sometimes is funky in web browsers, so just know that that might send you in a weird place. Or you can enter this custom year group, and we're going to come back to that in just a moment. By the way, month, kind of ignore that option even exists for suicide mortality data. In Utah, we don't have a lot of seasonality or month-to-month differences in suicide death, and so that's not going to really be much of a useful option for you. So the next thing that you need to do is select UDOH, injury causes, and then just click and just highlight all causes of death. This is going to give us firearms, asphyxiation, poisoning, and that other section as well. Any way somebody died by suicide is going to be included in our query. The next thing that you need to do is select suicide. And that is where this IBIS query really condenses and makes things clean and neat for you, or as clean and neat as possible. Any manner of death that was determined to be suicide is going to be reported in this query, no matter how it was coded on the back end, because we're going by manner, which is just clean and neat. If you're familiar with drug overdose surveillance, you know that that's a messy ordeal when you're trying to query those. So next you need to select the age of the decedent. And I put these in the most finite categories that you're going to want to go for statewide queries. If you're wanting to look at age groups, for example, in a local health district, if it's not Salt Lake or Utah County or Davis-Weber area, you're going to get into a lot of suppressed cells, meaning the counts are just too small to report. So if you're wanting to break down the data by a certain geography, it'd be really wise to use this alternative age breakdown that I propose here. And that's just widely used by CDC, NIH, NIMH, UDOH, and many others. And you'll get a copy of these slides when we're done, so don't worry about getting the details. So next you're going to go to select the sex, and the default includes both sexes, because remember our question didn't ask anything about sex or gender. Now, for those of you who are saying, what about gender fluid or gender diverse people? I know our death certificate data is not comprehensive enough to collect that data yet. We're working on it on a medical examiner side. We're the only statewide medical examiner system that's working on such an endeavor. I'm excited about it, but it takes a long time to get data that we can use. So the default here is both sexes, and we're going to select that. Now, if you wanted to compare males and females, select both male and female. But again, we're not going to do that. So I'm just going to leave that one unselected. The next is the geographic area. You can select by local health district, county, or by urban rural residence classification. And that actually breaks the state into 3 categories: urban, rural, and frontier. And then lastly, and this is where a lot of people get tripped up with IBIS, is how do we want IBIS to tell us the information we asked it to give us? I put geographic area there by accident and forgot to take a new picture of the screen, but I'm actually changing that to year in our query here today. But if I wanted to compare LHDs, I might say all LHDs above and then click geographic area. And IBIS also allows you to do one crosstab. So we could do gender and year so that we can look at how do rates change by, by sex over year, or by age group over year, something like that. But for now, I'm just going to leave the group by series as none, and then display by series, I'm going to select that as year. So next, we're going to select submit at the bottom, and then this is what comes up next. And I'm going to, for the sake of our eyes, because I know this is very small, I'm going to zoom in and just cut that a little bigger, or as big as I can. So we're going to do some data analysis here, but the answer that we get is that how many people died by suicide in the last 5 years? Well, the rate is 20.58 per 100,000. That's the crude rate. It's not adjusted in any way. And then the second thing that we get is 3,245, which was the answer to our original question. We could select none on that former group by feature, and it would get rid of all this breakdown by years. But I think that's actually really helpful because it's longitudinal data. It tells us what's happening over a period of time. Okay, so the other thing that we might want to do is visualize this data. And there's ways you can do that in IBIS. And I'm no offense to the creators of the people who did the visualization tools in IBIS, but I would much prefer to put this in Excel because I can then kind of manipulate it in the ways that I want to. So output to Excel is what you're going to select. Now, if you don't have Excel, you can use Google Sheets as well. You might just need to upload it from a downloaded file as an Excel file, or you can manually type it across, which is not great. But you can use Google Sheets to produce very similar kinds of things as we're going to do in Excel. So this is what it looks like after you download it into Excel. And I'm not going to give you an Excel lesson today. There's lots of YouTube videos out there that can tell you how to use Excel. But this is what it looks like. And now we can actually create a graph or a visualization of what this data looks like to help us understanding what's happening with suicide in Utah in the last 5 years. So I went ahead and did that. And this is what it's like. Now you're going to notice that I included both rates and counts. The blue line with the long dashes in it, that is counts. And the second line, that green solid line, that is the crude rate per 100,000. It's important to include both when you're doing looking at suicide data. And the reason for that is because the population is changing in this. So the rate, we don't know exactly what's happening with the rate, but also maybe the same number of people are dying by suicide. And really what's changing is the population, not the number of people dying by suicide. So we need to be cognizant of both. And that goes back to my previous, an example in just a minute. This is very basic, I know, but I get asked this question often, which is, why would we want to use a rate? And so here's a review, and I'm sorry for all the trauma that I've just inflicted on those of you who hated biostats, but this is how we calculate a crude rate. It's the number of cases or suicide deaths divided by the total population within a specific time frame. In this case, it's by year. We multiply it by 100,000 so we can actually see these numbers, and that is what's called the crude rate per 100,000. So here's why the rate is important. So in 2020, for example, there were 236 Salt Lake County residents who died by suicide. In the Central Local Health District, there were 20 people who lived there who died by suicide. Now, if I were Acme Charitable Trust, and we had, I don't think that exists. I made that up. If I had Acme Charitable Trust and I had $1 million grant to give, who would I give that $1 million check to based on the information I just gave you? I think it's a no-brainer. You'd give it to Salt Lake County because there were vastly more deaths there than there were in the Central LHD. But let's look at that by rate. So the rate of suicide in Salt Lake County in that same period was 20.3 per 100,000. In the Central LHD, it was 23.9 per 100,000, so a little bit higher. Now, I don't think that that's all the information I would need as a granting organization, but that certainly brings that back into question. We need more information about what kind of intervention are you proposing and that kind of thing. So that changes at least the metrics and whom I'm going to get my checkbook out for. Again, the other thing that rates do is they help us adjust for changes in the population, not just in differences in the numbers of suicides. Some counties in Utah are among the fastest growing in the nation, and others are actually experiencing a decline in their overall population. Rates standardize those changes and help us compare apples to apples, years to years, or what have you, and help us understand what's happening both over time and at any given point. So here I've added trend lines, just a basic linear trend line. This is a right click. If you right click on either line in Excel after you've built the graphic, you can add these trend lines, and they really distill it down to you about, is this going up or is this going down? But this gives us a pretty confusing picture, and we're going to go a little bit into the weeds here, but that's okay. Stick with me. So that long dashed blue line, that's a flat line that goes up, or a straight line that goes up, that is our trend line for our counts, and it's clearly going up. Whoops. something is, it's clearly going up. Now the shorter dashed line, the green dashed line that goes down is clearly, I'm sorry, Zoom is just acting up for me. Clearly going down. So we've got conflicting information between counts and rates. So let's just briefly talk about trend lines and how to interpret those. And it might seem obvious, but statistical significance tests also play a factor here. So if we're looking at both counts and rates going up over time, I think it's fair to say that suicide is going up, even if the rates are not statistically significant, still trending up. It'd be nice if they were going, for our interpretation's sake, it would be convenient, I guess is a better word, for that to all be clean and for the rate increase to be statistically significant. But oftentimes these numbers are so small that they're not. So we just have to do our best. And if both are going up, it's a pretty clear indication that suicide is increasing. Likewise, if it's going down over time, it's a fairly decent indication that suicide is decreasing. But what happens when these two bits of information conflict with each other over time? And that's the situation that we had in our actual data a few slides ago. We need more information to do that. And again, I'm in the weeds here, but stick with me. We're going to need to look at our confidence intervals. So here's where statistical significance can come into play and tell part of the story. 95% LL, which is that middle column in the red square, stands for 95% confidence interval lower level. And the 95% CIUL stands for 95% confidence interval upper level. So in simplified terms, that means that we're 95% sure that the rate of suicide in 2016, for example, is between 18.53 per 100,000 and 21.75. Remember, the actual rate is 20.9 over here that we're reporting, but we know that it's actually some error built into that because of the population estimate. So it's between those two. So let's just illustrate that. At the top here, you've got the figure we've been looking at for the last several slides. At the bottom, I've actually plotted out the upper level, that's the green line, and the lower level, the purple line. Now, at no point in this bottom figure does the green line go lower than any value in the purple line. And likewise, at no point does the purple line, the values of that line, go above the green line. So that means that there is statistically no difference between any of the points on our actual reported rate, which is the blue line. So now what would that look like if they actually were statistically different from one another? I made up some data from, I'm going to call it 2075 because I'll be either gone in some way, I'll be retired or just not alive anymore, whatever. But anyway, so we're going to say that the suicide rate in 2075 was 10.75. And then the next year it was 5.35 per 100,000. They had awesome suicide prevention that year. Things were great, really went down. Of course, the goal is 0, but hey, that's a great decrease. We'll take it. And so the lowest line, the highest value of that light bottom blue line, 9.25, is still higher than the highest value of that royal blue line, the top blue line, that at these 2 points. So that is a statistically significant change. All right, so let's come back out of the weeds a little bit. So sometimes we ask questions like what was happening with suicide in the state of Utah over time for the last 5 years. But sometimes context matters, and we have to look around our basic question to get the context, to get better answers than just the answer to our original question. So what I did here was add in 2015, and that lowered our linear trend line from -0.1 to -0.03. So it made it a lot flatter. That tells us that in the last 6 years, suicide rates really aren't changing a whole lot in Utah. But I would say that they are trending downwards, even though that change is not yet statistically significant. Context matters. So be sure to go beyond just your query and make sure that you know what's happening around it, not just in your clearly defined question. Okay, so you're going to put in some queries in IBIS, and I know this is going to happen to you because it happens to me all the time. By the way, when I get data requests, I would say I fulfill most of those data requests with IBIS. So it would be great if everybody became IBIS pros, because then you don't have to wait a year and a century to get data from me, because the line is long. Okay, so what happens if you cut data into too small of chunks, or the cells get, the counts in the cells get too small? It means you get really big error. And IBIS says, wait a minute, you need to yellow flag, you need to take caution when you interpret this, because the error here is huge. So I pulled Tooele County just by happenstance here. And I noticed in 2016, there's this asterisk by their rate. And over here on the right, the relative standard error is above 30. So that's where IBIS says, yellow flag here, use caution. Because remember, they're saying that their rate, or IBIS is telling us that their rate is somewhere between 5.34 and 24.36 per 100,000. So it's a big range there, and we should use caution. Now let's go a little bit smaller and go to Wasatch County LHD. Here, every single year has an asterisk by it, meaning that these rates go way up and way down. This variation is really big, but it's telling us that that doesn't really mean that there's a huge difference from year to year, statistically speaking. It also says that the count in 2019 was too low to report. So it just bleeps it out. And it also got rid of our totals so that we can't do some simple math and go backwards and figure out what the number of deaths was in 2019. So let's try to fix some of this error. So I just copied and pasted from the query, that's the top part of this slide, and I grouped years together. You can do that by just using a simple hyphen and connecting 2 years together. So I added 2015 back in so we can keep the number of years equal. So we're comparing 2 years to 2 years to 2 years. Okay, and then I just clicked it, submit at the bottom, and then this is what the output. It's much better. It's nothing is suppressed here. So we know that between 2019 and 2020, there were 6 deaths, and it gives us an actual rate. Still some really big error here, but at least I'm getting reportable results instead of just blank cells or a bunch of asterisks. Okay, so that's hopefully as much data analysis as I'm going to beat you over the head with today. But we're going to shift gears just a tiny bit and talk about some trends over time. So you're looking at a slide of actual data, and number 48 there, this is suicide counts by month. And you're looking at July 2018, where 76 people, when I was pulling that data, 76 people had died by suicide in that month. And I'm going, holy cow, Paris is burning, Paris is on fire, send up some alarms. I don't know what to do. I mean, this was like really pulling stakeholders together and wondering what to do. The other thing, I couldn't find any commonalities, and I still can't find any commonalities in why we had this really big peak in this 1 month. And unfortunately, I was put in an uncomfortable position of saying, okay, we're just gonna put the brakes on for a second and see what happens. And that's exactly what we did. And here's what happened. So in the next month, August 2018, they went back to essentially baseline. And then a couple of months later, went to one of the lowest points that we've had in the last 5 years. So I still don't know why that was a high point, but I know that that was a good time to look at the strategies that we currently had in place, start making plans for a revised strategy, a more aggressive strategy, if that we could have such a thing, or a more intense investigation into why that happened. But if I had deployed everything that we had in our collection of suicide prevention tools, then I'm not so sure that that'd be like crying wolf every time that we get one of these weird data anomaly spikes over time. Now, what you're also seeing is the last 5 years worth of data ending November 2021. So there is some medical examiner data in here that you can't get on IBIS. That's the last 12 months that you're seeing here. But the story that, as we reported in October 2021 in a special report, suicide rates are largely flat. Yeah, they're ups and downs, and it's normal variation, things that we expect to see month to month. We would love this line to go down, by the way. It's not great news that it's as high and as flat as it is, and we're kind of at a stubborn point where we're struggling to get it to go down, but it's not going up. And considering all of the things that have been happening in the last 2 years, almost 3 years, or 2 years, I guess, that's okay news. It could be much worse. So I'm going to give you a scenario, and we're going to call this the Smith County Suicide Prevention Coalition scenario. So they learned from their local sheriff that of 3 suicides that occurred in their county in the past 2 weeks, and they're rightfully concerned about an increase in suicide death in their county. So here's some considerations that you maybe need to take under advisement. So how many suicide deaths are typical in a 12-month period in Smith County? Certainly these happen closely together, but how many, what's normal or typical? Suicide's not normal, but how many are typical in a 12-month period? So let's just say that we looked that up on IBIS, and from year to year, it's about 35. So to the best of their knowledge, the coalition says, well, we think there's been about 37. Does that represent an increase? Not really, because remember, it goes up and it goes down. Next month, we might have fewer than we would typically see in years. So being that these 3 deaths happened in such a close, tight-knit time period for this place, I think there's cause for concern, but we need to ask some additional questions. Now, keep in mind, the population of Smith County might be going through the roof, and that might account for the increase in deaths that we're seeing as well. So our second question is, are the 3 people who died in Smith County connected to one another socially? Like, do they know each other? Did they go to the same ward or church congregation? Did they go work in the same place, or were they even friends? If that's the case, then that's definitely cause for concern. But for example's sake, we know from our investigations, or from what we know, that 2 worked for a local mining company and 1 was an electrician. And the families that have said that the 2 guys who worked at the mine, the 2 men who worked at the mine, didn't know each other. But we did find out that the HR division of the mining company announced to everybody in the mining company that, quote, this employee shot himself and died and would not be returning to work. Problematic for safe messaging. That should also raise some flags for us. Okay, so we need to ask another question, which is, were there any commonalities among these 3 deaths? For example, did they use the same method? Did they all go to the same location? Like, what I'm thinking about here is a Golden Gate Bridge kind of situation that's known for people to take their own lives. Or if it's a tight-knit community and there are a small number of racial or ethnic minorities, that is also something that we need to take under advisement. And lastly, this question here, by the way, for our example's sake, they all used a gun, they all died at home, which is not particularly significant, but that's really the only link there that we can establish. So lastly, did all of these guys, were they residents of Smith County, or does Smith County have a big hospital and somebody was flown in? Again, this happens all the time for Salt Lake County, for Weber because of McKay-D. And so that's simply because these people were at a higher level of care, or needed a higher level of care, and they were pronounced elsewhere. Now, one more consideration here, which is, where did this information come from? They learned it from the local sheriff. Now, that's not a bad source per se, but consider that the biases that source might have. Does the local sheriff have jurisdiction over the entire county? Or is there a city with a police department in that county too? Because the sheriff may not know the outcome of every suicide attempt that they respond to if a person was transported to a hospital. On the same side of the coin, maybe this is really an increase for that sheriff. Maybe they respond to 1 suicide attempt every week, and suddenly they had 3 in a week or this short period of time. So that does represent an increase for the sheriff, but it does not maybe represent an increase overall for the county, because the sheriff isn't getting the full picture of what's happening in the county. And that's where this becomes a real population health question, a public health question. For public health and considering what's happening in a place, we need to consider the entire population, not just what one police jurisdiction responded to, because just there's some complications with that. So the big question here is, does this information lead to any change of action for the Smith County Suicide Prevention Coalition? They appropriately develop a partnership with a local mining company. That's a great thing to do, where they promote recognizing the signs of poor mental health, aka increasing help seeking, reducing access to lethal means, and discussing safe messaging with the company's HR so that they don't announce company-wide that somebody quote unquote shot themselves. Rather, this person died or this person died by suicide. And then if there were no connections whatsoever between these 3 deaths, it's a really difficult position to be in as a coalition leader or the leader of an LHD or LMHA. In those situations, it's a bit of a waiting game. We need to see if these 3 deaths end up being sustained, meaning there's additional deaths, which is awful. Of course, we should always engage our suicide prevention strategies, but it doesn't necessarily mean that those 3 deaths need to mean that we change our strategy in that moment. All right, so that leads me to just a very brief discussion of what suicide clusters are. There are 2 types: point clusters. That means there are 3 or more deaths within a given period of time. Typically, we define that as a 12-month period, and that these deaths were, this is the key part, socially connected. So for example, they all went to the same school, they were incarcerated together at the same correctional facility, or they worked for the same company. They actually know each other. Another example, which the CDC and SAMHSA have used in some really great guides, is Tlingit villages in Southeast Alaska, where everybody knows everybody. They may not be best friends, but they know each other and they know these suicides are there. And we can link suicide 2, 3, and down the line back to suicide 1. Here, people are identifying their problems with person 1 and taking their own life. That happens in the second kind of cluster 2. This is called suicide contagion, by the way. Then there are mass clusters, and that's where we see this rate increase over time. That's abnormal. It's beyond normal variation. Usually we look at these in 12-month periods again, but there are commonalities, but these people don't really know each other. And so after Robin Williams died by suicide in 2014, we actually saw an increase in ligature-hanging deaths by suicide nationally, and particularly in that region, the southwest region of the US. The media reported that Robin Williams had a lengthy history with depression and that he died by suicide by hanging himself. That is a nasty ingredient for suicide diffusion. You've just told people who struggle with depression that one way that they can quote unquote deal with their problems is die by suicide. This is called suicide diffusion. Another example that's well documented in the research now is the increase in suicide attempts, both fatal and non-fatal, following the release of the first season of Netflix's 13 Reasons Why. So clusters require specific public health interventions that usually go beyond a community's suicide prevention plan. And that is for another day. Unfortunately, we have to leave it there, but we are going to talk about suicide contagion and diffusion, hopefully, I think, in a future presentation as well. Now, I'm really going to go through this very quickly, like in 2 minutes, because so much of it is the same. If you want to compare states, or there's things that you want to compare within Utah, a lot of that data is available in another data portal called CDC Wonder. So you can go there by going to wonder.cdc.gov. And like I said, I'm going to fly. So first of all, you're going to click on underlying cause of death. Then you're going to select this underlying cause of death by bridged race categories, meaning that they aggregated racial groups to get the most reporting as possible. You can get more recent years by single race categories here if you're interested in a specific race category. All right, so now you have to agree you're not going to break the rules. Now you're going to tell, just like IBIS asked you this at the end, how do you want us to group the data? Wonder asked you to do that at the beginning. I use year and state most frequently, going by year and then by state. Next, you have to select which states you want. I'm saying all of the United States. I want to be able to compare all 50 states to each other to figure out, for example, where Utah ranks, okay? So next I'm gonna go to which age categories I want. So if we wanted to look at teen suicide, we could do that here. We'd select single age groups there and select the individual years. Again, you can select multiple categories by holding down the control key. You can select other things here as well, but we're in a hurry. So we're gonna collect the dates that we want. You can select the specific year. I'm going to select 2020 here, for example, which I didn't include, or I didn't select it at the time I took the screenshot. Next, then this is the where Wonder gets a little bit more tricky than IBIS, okay? You have to figure, oh, by the way, ignore select number 5, just not helpful information. So you're going to scroll down in step 6, down to the external causes of mortality. All right, so V01 to Y89. All right, these are ICD-10 codes. You're going to select that, and then you're going to say open fully. Then you're going to scroll down, and there's a long list here, and select this category X60 through X84. Then hold down the control key and scroll down, and you're going to select Y87.0. So you've got those two things, and that's going to get the vast majority of the deaths that we're looking to look for here. All right. Then you're going to select basically how you select the totals, show the zero values, so show the suppressed values, and then press send. And then you're going to get the results. And then I click this arrow here, the red arrow that you can see. I wanted to see the states by suicide rate in descending from highest to lowest. And it turns out for 2020, Utah ranks number 9. It goes up and down every year. Safest way to message that, Utah has one of the highest rates of suicide and is consistently within the top 10. Okay, now we are 4 minutes left. You're going to get these slides, but I want you to know that the OME, the Department of Health, we're working to look at suicide clusters. We're monitoring suicide and drug overdose in real time. We're looking at aberrations. And if we see anything, we're definitely going to reach out to our partners in LHDs, LMHAs, LEAs, and community partners as well. We look at this data with other people at least monthly. So it's not just me and my biases looking at this data, but other people as well, and a host of other things. So lastly, here's where I'm going to leave you, which is ask these big questions before you start data queries. How will this data inform or change my suicide prevention strategy? Yes, we need situational awareness, but is it going to change our strategy? If you need it for grants or fundings, good to have that data there. And so sometimes you just need the information and you need it from a good source. IBIS and Wonder do that. I see you, Allison. I'm going fast. All right, so suicide deaths do not need to be, I mentioned this earlier, they do not need to be increasing to illustrate a need for prevention, intervention, or postvention. Everywhere in Utah, no matter where you live, the suicide rate is too high. There is already cause for you to go to your community leaders and say, we need suicide prevention, full stop. And lastly, don't make the episodic an epidemic. Yes, suicide deaths are so life-changing and so tragic. But if you message that as an epidemic, that one death or those 2 deaths represent an increase or suicides, quote unquote, going through the roof, that can work counter to what you're trying to do, which is prevent suicide deaths. Because in doing that, particularly if it's really not true, you're making what is a finite tragedy into an epidemic, and that might be the case down the road. You don't want to cry wolf. So informing a community in this manner can actually be dangerous because you might even be normalizing suicide. So when you need help, when you have questions, here's my email address. You can also go to vipp@utah.gov. They're helpful, very helpful as well. And then I'm going to turn it back over to Allison for the last 2 minutes.
So yeah, just to wrap up, I mean, we told you to buckle up. We weren't kidding, right? Like this is such useful information. It's a lot, but I hope that this makes you feel a little bit more confident in being able to obtain the information yourself, that this isn't something that's just housed here at the state level. This is something you have access to be able to get a picture of what's really happening in your communities. And sort of the last thing I'll leave you with is that you're not in this alone. Feel free to reach out to Michael, to myself. It's our jobs to sort of compile data and help you come up with plans for your communities. And so please feel free to reach out to us with any questions, concerns related to this information or just prevention planning in general. And know that if there is ever a concern that we have about your community, we will be reaching out to you and we'll have a strategy session. So thank you so much, Michael. I know we are pretty much at time, but we will be compiling questions and Michael will respond via email. Heather, do you want to say any final words?
There are a few questions that were asked that were addressed in the answered. So if you want to stay on, we'll keep this open. Just go to the Q&A to the answered so you can see those. We'll also be sure to include the responses to the questions that were asked in a follow-up email with the recording. This is one of a series that we plan on doing about the state prevention plan. So you can find the recording of the one that we did in November, and then also this one on dsamh.utah.gov in a couple of days. And if you want to make sure that you are on our mailing list for these webinars, please go ahead and just let me know in the Q&A box, and I'll make sure that your email is on there. And thank you again, Allison and Michael. There was lots of thank yous. We are so fortunate to have both of you in this work and for all of you to participate in being part of the solution. Thank you and have a good day.
Michael, you're still sharing your screen.